Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Thanks for joining us today for the last module in Summer School of Diabetes. My name is Rael Mazrou'i. I'm consultant endocrinologist from Tawam Hospital and STMC in Al Ain. And it gives me a great pleasure to moderate this session today. Today, our session or our module is the last module of the series. And this educational activity is supported by our educational partner, Lily. And we are thankful for their continuous support to our education platform. As you all know, the Summer School of Diabetes series is a series of 6 modules that in which the program objective is to cover different topics and themes across diabetes management. And today is the last session, which is module 6. It ran over 6 weeks, and you need to do a pre-module survey and MCQs, followed by again post-module MCQs in order to get your CME certificate. It is 6 modules. However, if you have missed any of these, you have still 1 month left. You can go back, do the pre-learning MCQs, and then go through the recorded modules, and then complete the post-learning MCQs in order to get your certification. The recorded sessions that you can view now for at least 1 month are available in the webinar in the EDS on-demand channel, as well as on the YouTube channel. Through our meeting today, please place your Q&A question in the Q&A session, so we will address them later after we finish all the talks. And if you have any issues with and you need technical support, please don't hesitate to contact our team through the chat box. So the program today have 4 sessions around the theme of diabetes complication from risk to prevention. And our first session will be about macrovascular complications, screening, monitoring, and referral. And it gives me a great pleasure to introduce our first speaker, Dr. Hani Sabbour, who is very well known consultant endocrinologist and cardiac electrophysiologist, currently based on Mediclinic Hospital in Abu Dhabi. Dr. Hani, thanks for joining us, and the first screen is yours, so you can share your presentation on presentation mode.
Sure. Thank you very much. Can we see the slides? Yeah. There.
Yes, we can.
That's right. Okay, so let me just start at the beginning. So I'm actually very glad to be part of this program, and it gives us something very important to do in the summer rather than just taking vacation. I think these are very important concepts, and I think it's a good time to review. So the context that we're talking about today is macrovascular complications, screening, monitoring, and referral. So one of the things that's important is, why do we need to do this? Why do we need risk assessment in cardiovascular prevention? So first of all, to identify risk in large asymptomatic populations to prevent the first event. This is very important in diabetes. To quantify and target who needs more intensive therapy. To identify individual patients who need to initiate more preventive therapy from the beginning, and also identify specific LDL targets to be achieved in an individual patient, and the addition of aspirin based on the risk. And in patients who have already had an event, to intensify more advanced therapies in patients who have had a secondary prevention. So there are many risk calculators. Which one applies to our population in the UAE and your individual patient? This is really kind of complicated. And this is a summary from the European Society of Cardiology talking about different risk scores. And in fact, in diabetes, there are 2 validated ones. One is called the Advanced Risk Score, derived all these from the Advanced study, and the other one is from the DIAL study. This looks at 5 to 10-year risk. That's one. Other looks at lifetime treatment effect. And I think the key point is it's also helpful to use these calculators for a reason, that is to talk to the patient and tell them, if you give this intervention, what happens to your LDL? When you lower the A1C, what happens to your cardiovascular risk? So it helps you as an educational tool. But does this truly apply in the UAE? So one of the things that we learned from this very nice study that was done by Dr. Sharif Bakir and Dr. Wael Mahamid and a group from the university is that they looked at all of the risk scores that are available. The pooled risk equation, the European score, the NCP, ATP, the Framingham, and they found that there was only a 55% agreement between that and the patient's true cardiovascular risk. In fact, they took a cohort of 2,000 patients in Abu Dhabi who already had a heart attack, and they calculated their score the day before they had the heart attack to see, does this predict the heart attack in these younger patients? And the answer was no, miserable, right? 50% is tossing a coin. So this really has led us over the last many years to try and see how we can refine and improve this process in the UAE. Due to the young age of patients with events, risk calculators are highly dependent on age, and therefore this is where these systems and scoring systems from outside the UAE fail. Now, in general, and this is sort of a simplification, the European Society of Cardiology came up with this sort of context of high and very high risk diabetic patients. Who are these patients and what does it try to do in terms of their action? So first of all, a patient with diabetes without target organ damage, or a patient with diabetes more than 10 years, or a patient with diabetes with any single risk factor is automatically classified as high risk, and therefore has to have an LDL target of less than 1.8, among other things. If your diabetic patient has target organ damage, and here they included microalbuminuria, retinopathy, neuropathy, or LVH, or simply having diabetes and 3 of the major risk factors such as age, male, obesity, smoking, hypertension, elevated cholesterol, elevated triglycerides, postmenopausal women, these become very high risk. In addition, patients with type 1 diabetes of long duration, more than 20 years, are also very high risk. And of course, any diabetic patient who sustained an unfortunate cardiovascular event, peripheral artery disease, or a stroke are extreme high risk. So here is the LDL target for these patients. Now, in addition, they have qualified patients based on non-diabetic patients based on the presence of atherosclerotic cardiovascular disease or cardiovascular events, or patients with familial hyperlipidemia and severe CKD. These are important because these patients may not have an event, may not have diabetes, but they still are qualified as high and very high risk. Now, one thing that we have noted is that the European Society score, the calculator score, is not validated in UAE because of new young age of onset, underestimates cardiovascular risk. So if you're going to use a calculator, use it only if it calculates to high. Do not use it if it gives you the wrong number. So the other population that's also high risk is this: patients who are unable to take statins, intolerant to take statins, or either due to LFT abnormalities or CPK. These patients have higher risk because they cannot take the standard preventive therapy and therefore need PCSK9 or ezetimibe. In any case, regardless of their ability to take or don't take statin, their risk doesn't change, neither does their target. You just have to add more medication to their regimen. So one of the things that we also have not discussed, but is coming into the literature a lot, is the impact of non-adherence. In this is the European Heart Prevention Study. Patients who are called or defined as adherent if they take more than 80% of their cardiovascular medications or diabetes medications over the year. In Europe, 1.9 million patients had 135,000 cardiovascular events and 95,000 cases of mortality. 40% poor adherence in Europe. You know, we all think that the Europeans are very organized and very adherent. Well, apparently not in Europe. And 9% of all these cardiovascular events could be attributed to poor vascular adherence alone. And if you look at the hazard ratio of non-adherence to any cardiovascular medication and anti-diabetic medication, aspirin, simply being non-adherent increases your hazard ratio significantly. And it is therefore another risk factor in cardiovascular risk. It's well validated as well. So think about that. Your non-adherent patients are going to be at higher risk anyway. So one additional component that I think is really important are what are called risk enhancers. This was extremely well described in the 2018 ACC guideline and the 2019 ESC guideline. And I think it's important because these are things that are not intuitive. You have to memorize them or put them on your desk or use them to capture these patients. It's very important in the younger patients and also in females. So in women, premature ASCVD risk factor, which means less than 55 in males or less than 65 in females. South Asian ethnicity. Many of our patients and even our colleagues are South Asian ethnicity. That increases the risk due to genetic factors. In women, the presence of preeclampsia, premature menopause, or polycystic ovary disease increases the risk of cardiovascular events. If your LDL is high, over 4.0 or 160, this is called primary hypercholesterolemia. If the triglyceride is over 175, this is another very powerful risk enhancer, regardless if you have diabetes or no diabetes. And other conditions that increase the risk include an ankle brachial index that's less than 0.9, as an abnormal, lupus or chronic inflammatory conditions such as rheumatoid arthritis, hepatitis C, AIDS, or vasculitis, metabolic syndrome. Of course, this doesn't apply to diabetics, but patients with insulin resistance, and chronic kidney disease with or without albuminuria is also a risk enhancer. So if you look at your data individually for your patients and ask these additional questions, you will find a lot of these patients have some CKD, have some chronic inflammatory condition, have hypertriglyceridemia, and this is an impact on how the risk is classified. Any one of these increases the risk by one-fold. And the ankle brachial index is something that we have recommended in the UAE cardiometabolic guidelines. It's a very simple test. It reclassifies risk in the outpatient setting completely. If the patient has an abnormal ABI, they have peripheral artery disease and established atherosclerosis. So what are the thresholds? In a diabetic patient, an ABI less than 0.9 is abnormal. In a non-diabetic, less than 0.8 is abnormal. And if it's more than 1.4, that means the vessel is hard and stiff and calcified and also has atherosclerotic cardiovascular disease. This is a more specific for familial hyperlipidemia. Very important to realize if your patient has diabetes and familial hyperlipidemia, they automatically become extreme high risk. And you don't use a calculator in these patients. You simply need to treat with combination therapy. So I'll come to the complications of diabetes. So all of what we are doing right now, either risk scoring, risk enhancement, or risk assessment, is to try and prevent the macrovascular complications of diabetes. So what are we looking for in daily clinical practice? So number one is atherosclerotic cardiovascular disease. This is a major killer in patients with diabetes. And the problem is that it could be atypical or silent in diabetic patients due to autonomic and peripheral neuropathy. The risk is amplified by the presence of CKD, hypertension, dyslipidemia, and smoking. Ask direct questions such as chest pressure, exertional dyspnea, reduced exercise tolerance. Direct questions are needed here. You have to prompt the patient. You can't ask them, are you having shortness of breath now? You tell them when they walk, do they have shortness of breath? The next is cerebrovascular disease. There's an increased risk of TIA and stroke, and coexistence of atrial fibrillation and diabetes is a major component of this. Also, you have to ask in the history about transient weakness, blurred vision, speech disturbance. Peripheral artery disease. Claudication is often underreported in these patients because they are often obese or sedentary and they don't walk. If they do walk, they can start having leg cramps, so they stop walking and now they take a wheelchair. So foot ulcers and poor wound healing may be the first clues. You must examine the pedal pulses and inspect the feet. And heart failure is extremely common in diabetes and often under-recognized, again, because of the sedentary nature of the patient's lifestyle. They don't exert themselves, therefore they don't feel short of breath. They just sit in the chair all the time, or they use a wheelchair. So heart failure with preserved ejection fraction is very frequent in obesity and type 2 diabetes. You have to ask specifically about odd patterns of dyspnea, including walking that is now reduced, lower limb edema, fatigue, and reduced functional capacity. Routine review should include for symptoms of ischemia, dyspnea, and claudication, and in addition to blood pressure, lipids, smoking, checking for CKD and albuminuria, foot exam and pedal pulses, and heart failure biomarker screening. Now, while not every patient requires an imaging or stress test, every patient needs structural cardiovascular disease surveillance. So how to screen? So who to screen, how to screen, and what to not do routinely. So coronary artery disease, asking about symptoms. The biggest symptom that's important is unexplained fatigue and reduced effort tolerance. Obtain an ECG annually, as is recommended in the UAE guidelines. An abnormal ECG, any kind of symptoms, or the presence of vascular disease or high cardiovascular risk should promptly lead to testing. If these patients have an abnormal ECG and an abnormal biomarker, in this case, stress testing or coronary CT angiogram may be recommended. If the patient is totally asymptomatic, that may not be appropriate. So, unless the ECG is abnormal. Next, we look for heart failure. Heart failure is a very vague symptoms in these patients. You can have dyspnea, you can have orthopnea, you can have lower limb edema, which can be attributed often to amlodipine or exercise intolerance. Now, NT-proBNP is now recommended by the American Diabetes Association and the UAE cardiometabolic guidelines and the UAE diabetes guidelines on an annual basis. If the NT-proBNP is elevated, even if there are no symptoms, echocardiography is recommended. Now, do not ignore subtle dyspnea or fatigue as deconditioning or overweight or simply sleep apnea. Dyspnea and fatigue are signs of reduced cardiac function. Next, peripheral artery disease. If you have claudication, the patient has to walk to exhibit claudication. If you examine the pedal pulses, you can feel it. In asymptomatic patients or high-risk patients such as diabetics, consider an annual ABI. This is also part of the guideline. So the presence of overt claudication symptoms, if you can't feel the pulses, non-healing wall ulcers, elderly patients or more than 10 years of diabetes, again, all of these patients benefit from having an ABI even if they have no symptoms at all, especially if there's a history of smoking. Now, do not assume that the patient does not have peripheral artery disease if they don't complain of classic claudication. That's why the ABI is essential. Cerebrovascular disease, ask about blurred vision, visual loss, or temporary weakness. Also, the ECG will help you to find or screen for atrial fibrillation. It's very common that you have atrial fibrillation, and when you're having diabetes, your CHA2DS2-VASc score is going to be elevated and needs to be on treatment. Focal neurological symptoms are also very important. And of course, that needs urgent evaluation in the emergency room with a MRI or a CT. Now, you don't do a routine carotid Doppler in patients who are asymptomatic. However, if a patient has a carotid bruit on physical examination or a history of TIA, then a carotid Doppler will be strongly indicated in this case. So to summarize, NT-proBNP, heart failure detection, annual, ankle brachial index for prediction of peripheral artery disease, echo if there are symptoms or abnormal natriuretic peptide, and stress tests and coronary imaging if there's an abnormal ECG and suspicious symptoms or biomarkers. So screen clinically, test, and intensify the therapy. Now, what are the red flags that are important? And this is a practical decision-making for the evaluation. So patients with diabetes at the routine visit. As I mentioned, the annual cardiovascular review includes a detailed history, including exercise intolerance, claudication or wounds, ischemia, the presence of abnormal stroke-like symptoms, plus blood pressure, lipid, smoking history, and albuminuria. BNP and ABI. Now, if there are no symptoms or no red flags, simply optimize the preventive therapy, including lipid lowering and blood pressure control, smoking cessation, and adding diabetes medications with cardiovascular benefit, as well as weight management. If you have abnormal findings, chest pain or anginal equivalent, or an abnormal ECG or AFib, immediate referral to the cardiologist, stress and echo are imaging as recommended. NT-proBNP abnormal in terms of screening, or new onset of dyspnea and edema, again, echo and cardiology and heart failure referral. If the patient has claudication symptoms or reduced pulses, then again, these are patients that need to be referred to the stroke neurology pathway. So the red flags are suspected acute coronary syndrome, so intensification of chest pain or shortness of breath, new neurological deficits, new ECG changes, heart failure, and peripheral artery disease with gangrene or non-healing ischemic ulcers. So recognition of high-risk disease and timely referral is important. Now, in the UAE, I think we have a unique advantage. In 2023, we worked to publish the UAE Cardiometabolic Guideline, which was a joint Emirates Diabetes Society Emirates Cardiac Society work that many of the faculty and many of the attendees were part of this extremely important work. And an updated Emirates type 2 diabetes consensus was published this year and presented at the Emirates Diabetes Annual Meeting. And I think this is very important. The whole concept here is intentionally proactive because diabetes and cardiometabolic diseases in the UAE present at younger ages with a high burden of premature cardiovascular events. So what we're trying to do is early identifying cardiovascular damage in diabetics and pre-diabetics. This is unique and different from the American Diabetes Association approach. We recommend an annual ECG, biomarkers and ABI, also coronary calcium score and plaque imaging and functional testing in patients who are selected at higher risk or symptoms, and early multidisciplinary referral for patients who are positive or very high risk. The Emirates Cardiovascular Risk Consensus in type 2 diabetes also recommended annual natriuretic peptide screening in diabetic adults, selective screening with high sensitivity troponin and CRP, adding prognostic information, and fast-track cardiology referral. And of course, if you have abnormal biomarkers, you trigger organ protective therapy intensification, including SGLT2 inhibitors, finerenone, and GLP-1 receptor agonists where appropriate. And the updated Emirates Diabetes Type 2 consensus from this year, again, individualized cardiometabolic risk, target organ protection, moving beyond glucocentric care towards weight, cardiovascular and renal outcome, and incorporates the UAE cardiometabolic risk framework for special identification of younger patients. Also of note, and I think this is very important, is that we recommend screening from a much earlier age. We are talking about screening at the age of 30 in patients, and also to include pre-diabetics as well. So this is favoring earlier risk detection and referral, especially when the diabetes coexists with multiple risk factors, as we see here, including hypertension, CKD, obesity, and effort intolerance. What are the proactive screening tests that we have recommended in the guideline? An annual ECG in every patient, okay? Any abnormality, including AFib or ECG changes, cardiac assessment. NT-proBNP annually using a cutoff point of 125 in the outpatient setting. High sensitivity troponin combined with BNP indicates cardiovascular damage and refines referral, and maybe more imaging is required. Ankle brachial index annually in the clinic. Again, a cardiovascular risk modifier, identification of peripheral artery disease. If you have plaque in your legs, you're going to have it in the heart. That's the objective. Coronary calcium score. In asymptomatic moderate risk patients, if you have risk enhancers, coronary calcium score may be done and repeated in 5 years. And coronary imaging, including CT angiogram or ischemia assessment in patients who are asymptomatic but have an abnormal ECG or elements of risk enhancement and higher cardiovascular risk. So it is more proactive than many international standards for asymptomatic screening. However, these biomarker and imaging decisions are tailored to the local policy and approved by both Abu Dhabi Department of Health and Dubai Health Authority because it is valuable in early detection and risk assessment in a high-risk younger population. What were the clinical referral red flags that came from the UAE cardiometabolic guidelines? Chest symptoms, ECG changes, palpitations, atrial fibrillation or other arrhythmias, heart failure, dyspnea, pedal edema, lung congestion, and elevated biomarkers. Syncope or loss of consciousness may be due to autonomic neuropathy or ischemic neurological events, peripheral artery disease, and of course, patients who are asymptomatic with very high risk with positive abnormal ECG. The fast track pathway, any patient with any of the points listed on the left, fast track to see the cardiologist within 24 hours, maximum 48 hours. Targeted testing at point of care, i.e., if you have heart failure type symptoms, rapidly obtain an NT-proBNP and ECG. This is fast track cardiology referral. In addition, if the patient has exertional dyspnea, cannot go up one flight of stairs, or lower limb edema, or progressive fatigue, they have to be seen by the cardiologist immediately. And also, while you are referring to the cardiologist, intensify treatment. So if the patient has suspected coronary artery disease, addition of an antiplatelet therapy. If the patient has confirmed atrial fibrillation, addition of an anticoagulant. If the patient has heart failure signs or elevated biomarkers, adding an ACE/ARB or ARNI, adding SGLT2 inhibitor are very important. Podiatry and vascular assessment for claudication, presence of ulcers or limb-threatening ischemia or absent pulses, rapid referral within the same day to the vascular surgeon. And screen-positive patients require prompt reassessment. So once you have started the treatment, it's not done. You have to reassess them again within 2 to 3 months. Repeat the BNP, repeat the ECG, look at the preventive therapies. Are they working or not? So the emergency pathways, however, we stated were acute coronary syndrome, acute neurological event, limb-threatening ischemia, or decompensated heart failure. Those patients have to be seen in the emergency room setting. So with that, I thank you very much, and I hope we have some time for discussion and questions.
Thank you so much, Dr. Hani, for being on time and for the elegant focus talk to the point. Thanks a lot for that. And now we will move to the second presentation with Dr. Mark Sabitian, where the talk will be about dyslipidemia and hypertension in people with diabetes. Dr. Mark is the chairman of thrombolysis and myocardial infarction study group, and he is the distinguished chair in cardiovascular medicine, Brigham and Women Hospital, and the professor of medicine, Harvard Medical School. I think his talk is recorded, so please start the recording.
Hello, it's my pleasure to join you for this session, and today I'll be talking about dyslipidemia in people with diabetes. Here are my disclosures. Let me start with some foundational data, and I'll start with the data we have for statins in patients with diabetes. And I'll show one representative trial here. This was the CARDS trial that was conducted now more than 20 years ago and came out in The Lancet. This trial enrolled about 2,800 patients with type 2 diabetes, and they need to have at least one high-risk feature. That could include retinopathy, albuminuria, recurrent smoking, or hypertension. They were between 40 and 75 years of age. Importantly, they had no documented history of cardiovascular disease, and their LDL cholesterol needed to be below about 4.1 millimoles per liter. On the right-hand side of this graph, I showed the cumulative incidence for major cardiovascular events, and you can see that those randomized to atorvastatin, in this case shown in the light blue, had a lower risk for major cardiovascular events with a 37% risk reduction. We can also look at the data from the cholesterol treatment trialist collaboration. These were data published in the 2010 analysis that put together data from about 24 trials. These trials included patients with and without atherosclerosis, with and without diabetes, and from each of the trials, we're able to cull out the subgroup of patients who had diabetes, who again may or may not have had known atherosclerosis. And I show here the forest plot. Here we're looking at the relative risk reduction for major cardiovascular events per millimole per liter reduction in LDL cholesterol. And you can see for diabetes that whether the individuals had no diabetes, type 2 diabetes, or even the small number who had type 1 diabetes, that there was no heterogeneity in terms of the benefit. All of them showed about a 20 to 22% reduction in risk per millimole per liter reduction in LDL cholesterol. I'll also draw your attention to looking at the event rates. These are event rates per annum. If you look in the control arm, you can see, not unexpectedly, that patients with type 2 diabetes were at higher risk than patients without diabetes, an event rate of 5.1% per year versus 4%, and type 1 diabetes was at higher risk still at 6% per annum. So reinforcing these are high-risk individuals, and so even though they have the same relative risk reduction with lipid lowering, they tend to enjoy even larger absolute risk reductions because they're at higher risk. Okay, let's move on now to other lipid-lowering drugs beyond statins, and here I'm showing data for ezetimibe. This is from the IMPROVE-IT trial that we led here in the TIMI study group, and this trial was led by Chris Cannon and Bob Giuliano. And overall, ezetimibe reduced the risk of major cardiovascular events in this trial. Here, what they did in this subgroup analysis was to stratify the results based on whether patients had diabetes or not. Those with diabetes are shown in red, those without in blue. A couple of observations. First, if you just look at the event rate for the control arm, which was placebo plus simvastatin, which was the background statin, that's the P/S column, you can see that those who had diabetes had higher event rates for all of the different outcomes. For the primary endpoint, 45.5% versus 30.8%. And if we look to the plot on the right, we can see that those with diabetes, if anything, enjoyed slightly greater relative risk reductions, right? A 15% relative risk reduction in the primary endpoint. So the addition of ezetimibe to background statin therapy helps reduce the risk of major adverse cardiovascular events in patients with diabetes who are at higher baseline risk. All right, let's move on now to think about guidelines. Now, these are the 2025 focused update of the 2019 EAS guidelines for the management of dyslipidemias. It's a 2025 focused update. The risk classification, which is what I'm focusing on now, is quite similar to what came out in 2019. And I'll highlight here in yellow how diabetes works its way into the different targets that we recommended with these guidelines. And so let's start on the upper left-hand side. So for young individuals, those are those with type 1 diabetes who are under 35 years of age, or type 2 under 50 years of age, and they have a duration of diabetes that's under 10 years, and they don't have other cardiovascular risk factors, there the recommendation is to keep the LDL cholesterol under 100 milligrams per deciliter. If we move up in risk next to the high risk category, these are people who have diabetes. They don't have target organ damage, but they have a duration of at least 10 years, or they have some additional cardiovascular risk factor. That's kind of like the CARDS population that we looked at. In that group now, the target is getting an LDL under 70 milligrams per deciliter. Then we can move up to the very high risk category, and patients with diabetes get into that if they have target organ damage, or if they have 3 major risk factors, or they have early onset of type 1 diabetes of a long duration now of at least 20 years. And in those individuals, at least the 2025 guidelines would recommend getting the LDL under 55 milligrams per deciliter. I'm going to show you data where I think for patients with diabetes who aren't even necessarily at high risk, or at least aren't at very high risk, even the high risk category, that we really need to be much more aggressive than just being happy with a target of 70 or even 55, I think isn't enough. So I'll show you those data in a little bit. First, I want to go across the Atlantic to the US guidelines. Now, these came out in 2026, the ACC-AHA guidelines, but I'll note that these were based on data only through December 2024. And I've pulled out the flow chart for patients with diabetes. And again, I think the theme here is, I'd say, relatively conservative targets. So for those 40 to 75 years of age, start with a moderate intensity statin and target an LDL just under 100 milligrams per deciliter. So not very aggressive. If they have a 10-year risk that's at least 10%, or they have multiple risk factors, then consider ratcheting up. It's still a 2A, consider ratcheting up to a high intensity statin and having that target be under 70 milligrams per deciliter. And then, sort of surprisingly, on the right-hand side, if they're older than 75 years, and the only recommendation is for a moderate intensity statin. Again, I think we're not doing a service to our patients with diabetes with these relatively conservative targets. So let me share some of the data that I believe now support more aggressive targets for lipid lowering in patients with diabetes. I'm going to talk about the Vesalius CV trial, or TIMI 66, We presented this at AHA 2025. And I'll start just with an overview of the trial, and then I want to drill down to those with diabetes. So overall, the trial enrolled over 12,000 patients. They needed to have atherosclerosis or diabetes, but no prior MI or stroke. And then they were randomized to evolocumab or matching placebo and followed for a median of 4.5 years. The LDL cholesterol over time, we can see with the addition of evolocumab to background therapy, reduced the LDL cholesterol down to a median of just over a millimole per liter. So in this case, about 45 milligrams per deciliter. What about clinical events? So you can see a 25% relative risk reduction for coronary heart disease, death, MI, or ischemic stroke. The curves start to diverge after 6 months or so, 6 to 9 months, and then really continue to separate out over time. Also of note, 21% nominal reduction in cardiovascular death. And for all-cause death, a nominal 20% reduction. Again, the curves remain overlapping in the first year and a half or so, as we see for statin trials. And then after that, that benefit to the vasculature that we've achieved by lowering the LDL cholesterol then starts to translate into a reduction in all-cause mortality. Now, an important point here I'm going to illustrate is using the cholesterol treatment trialist collaboration meta-regression. So these are graphs from the 2005 and 2010 publications. And what these meta-regressions do is each statin trial is one black square. Where it sits on the x-axis in each plot is a function of what the LDL cholesterol difference was between the two arms in the trial. Where the trial sits on the y-axis reflects what the relative risk reduction was for the outcome, either major coronary events on the left or major vascular events on the right. And it's from this regression work that we have these lines that suggest that for each millimole per liter we reduce LDL cholesterol, we see about a 22% reduction in vascular events. Now for Vesalius, here's where it sits on these meta-regression plots. It falls perfectly on them. And that's important to note because this tells us that in Vesalius CV, where we got the LDL cholesterol down to 45 milligrams per deciliter, because the benefit we see is completely consistent with the prior statin trials, and we see this per unit reduction in LDL cholesterol, this implies that we're seeing that benefit for lowering all the way down to 45. If, for example, there wasn't benefit to getting these individuals down to 45, let's say we just needed to get them down to 70, then that extra LDL lowering wouldn't achieve anything. And the Vesalius CV trial should fall off this line. The benefit per unit reduction shouldn't be as robust. But because it is as robust as was seen previously, it really supports the notion that there is benefit, full benefit, for lowering all the way down to what we achieved, which was 45 milligrams per deciliter. So as promised now, let me dive into the diabetes subgroup. So to have diabetes and get into Vesalius CV, you need to have high-risk diabetes. And so that was either microvascular disease, so either nephropathy, retinopathy, or neuropathy, chronic insulin use, or duration of at least 10 years. And so about 6,000 patients came into the trial with high-risk diabetes. I show some of the baseline characteristics here. About half were women. Now, about a third of these individuals did have qualifying atherosclerosis. Again, they couldn't have an MI. They couldn't have a stroke, but they might have some amount of CAD or cerebrovascular disease or PAD. I'll dive into more detail for this subgroup and the converse, those without qualifying athero, in a little bit. In terms of lipid-lowering therapy, 91% were on some form of lipid-lowering therapy. More than 70% were on a high-intensity regimen. 87% were taking a statin. 2/3 were taking a high-intensity statin. About a sixth were taking ezetimibe. What about the baseline characteristics? So for the high-risk features, you can see most of what really drove this was a duration of at least 10 years for the diabetes. And so that, really would just be kind of the high-risk category in the ESC guidelines, not the very high risk. About 30% did have microvascular disease, 42% had chronic insulin use. In terms of other glucose-lowering medications, the usual suspects, about 3/4 were taking metformin, 42% on insulin, some on a sulfonylurea, some on DPP-4 inhibitors. And then for glucose-lowering medications that have cardiovascular benefit, for SGLT2 inhibitors, about 1/6 were on them at baseline. That went up to close to 1/3 at any time in the trial. And again, for GLP-1 receptor agonists, about 10% at baseline and close to 20% at any time during the trial. The LDL cholesterol substudy in the high-risk diabetes subgroup looks very similar to what we saw in the overall trial. Again, the achieved LDL cholesterol in the evolocumab arm, just a little bit over 1 millimole per liter, right? About roughly 45 milligrams per deciliter. So in these high-risk patients with diabetes, what was the benefit of evolocumab on top of background therapy? Here I show you the 3-point MACE to remind you that's a composite of coronary heart disease death, MI, or ischemic stroke, and you can see a robust 29% relative risk reduction. Robust reduction here in 3-point MACE. Similar data for 4-point MACE, 21% reduction. This now includes ischemia-driven revascularization. What about for other outcomes? I've shown you the dual primary endpoints for 3-point MACE and 4-point MACE. We had a variety of other composite outcomes tested in a hierarchical order. And you can see for all of the composites, again, roughly a 25-ish or so percent reduction in all these outcomes. And then what about individual outcomes? Obviously not specifically powered for that, but 35% reduction in myocardial infarction, 22% reduction in ischemia-driven revasc. Coronary heart disease death was infrequent, and so the confidence intervals are wide, and they cross the line of unity. But I will draw your attention to what we saw similar to what we saw in the overall trial for all-cause mortality. Again, a nominal 21% reduction in all-cause mortality with the addition of evolocumab to patients with high-risk diabetes, right, without prior MI or stroke, reduction in all-cause mortality. Now, let me dive into some key subgroups. So first, I mentioned that patients needed to have at least one high-risk feature. Here we show that whether they had 1, 2, or 3 high-risk features, there was no heterogeneity. The benefit was consistent. Next, what about their baseline lipids? Regardless of the baseline lipids, no heterogeneity. And this perhaps is the most important subgroup, those with and without qualifying atherosclerosis. As I mentioned earlier on the baseline characteristics, about 1/3 of these patients did have qualifying athero, but another 2/3 did not have qualifying athero, so about 4,000 patients. And you can see they benefited just as much. Again, roughly a 30% reduction in 3-point MACE. So patients with diabetes without qualifying athero, the addition of evolocumab reduces the risk of MACE by about 30%. And then lastly, regardless of concomitant use of an SGLT2 inhibitor or GLP-1 receptor agonist, again, the benefit entirely consistent. Now, I can expand this out a little bit and talk about any patient in VESALIUS-CV with diabetes. So this includes individuals, another 1,100 or so, who didn't have high-risk diabetes, but did have diabetes. They came in because they did have atherosclerosis, so we need to acknowledge that. But again, the results look very similar here. 32% reduction in 3-point MACE, I show that on the left, and a 22% reduction in 4-point MACE, and I show that curve on the right. And then we have a little bit of data for patients with type 1 diabetes. Again, we know these patients are at very high risk. They obviously tend to develop diabetes earlier. And so that then leads to a greater burden of atherosclerosis and vascular damage. And you can see, even though obviously not powered for statistical significance by any means, we only have 162 individuals with type 1 diabetes. Nonetheless, look at the hazard ratios for 3-point MACE, a hazard ratio of 0.41, for 4-point MACE, a hazard ratio of 0.55. And so trends here for basically halving the risk of complications of MACE with the addition of evolocumab in patients with type 1 diabetes. So let me summarize. In high-risk diabetes patients without prior MI or stroke, the addition of evolocumab to baseline lipid-lowering therapy resulted in the following: a median achieved LDL cholesterol of around 45 milligrams per deciliter, 29% reduction in 3-point MACE, 21% reduction in 4-point MACE, a nominal 21% reduction in all-cause death, Consistent benefits across subgroups, importantly, including in those without qualifying atherosclerosis or who were on an SGLT2 inhibitor or GLP-1 receptor agonist. And lastly, the magnitude of benefit I've shown in Vesalius normalized to the amount of LDL cholesterol lowering was consistent with prior meta-regression for statin therapy. And I didn't show these slides, but the same is true in the diabetes subgroup. And so what can we conclude from that? Well, these data really support a single LDL cholesterol target, I would say of right around 40 milligrams per deciliter for all high-risk individuals living with diabetes, regardless of where they are in their continuum of their ASCVD course. So I think we can throw out the guidelines that say, let's look at the diabetes risk and exactly how many risk factors you have. If you meet the criteria here, so it's not any diabetes, to be fair, it's diabetes with at least one risk factor, one high risk feature. But once you have that, you see the benefit for major adverse cardiovascular events, for all-cause mortality. And we got individuals down to about 40 milligrams per deciliter, 45 milligrams per deciliter. And so that's why I think we should target for our patients with diabetes with at least one high-risk feature. So thank you very much for your attention and look forward to the question and answer.
Excellent. Thank you for this elegant presentation and comprehensive review. Hopefully, Dr. Mark could join us in the Q&A session, and I would like to remind the audience, please place your question in the Q&A session. So we'll discuss them in the session, in the Q&A box. Please mention the physician to whom you direct, the speaker to whom you direct your question, and then follow that with your question. Try to be specific in your question so we can tackle most of the question that we will receive. Now, moving to our third talk, which is titled Connecting Treatment in Type 2 Diabetes to Outcomes, and our speaker is Dr. Alauddin Bashir. Dr. Alauddin is well known for his continuous support to the activity locally and regionally, and he's a consultant endocrinologist in Dubai Hospital and the clinical professor of endocrinology in MBRU. Welcome, Dr. Ala, and the floor is yours. You can share your screen.
Thank you very much, Dr. Raya. Actually, my talk today is basically a summary of all previous talks that we have seen or we heard over the last couple of weeks. And today I'm going to discuss how to connect the treatment. Do you see my screen?
Yes, we do.
Okay. So today I'm going to discuss the connection of treatment in patients with type 2 to their outcomes. And as I mentioned, this is basically a summary of all the previous talks. Now, if we talk, the learning objectives in this presentation is basically my first aim in this talk is to reframe the goal and move people away from a glucocentric approach to having both glucose and A1C as well as organ protection as a first target in management. And to do that, I need to go through the evidence with all the trials, whether randomized controlled trials or meta-analysis that is available. And by the end of this, I'll be able to match the phenotype to the treatment. And then we look at the separate mechanisms that these medications work, whether they reduce the glucose or they act independently of A1C. And to start, I'd like to keep this patient as a reminder, hold it in your mind. And then at the end of the presentation, we're going to see what we can do for this patient. This is a male who is 52 years old, newly diagnosed type 2 diabetes. His A1C is 8.2, his BMI is 34, and his EGFR is 74. Albumin creatinine ratio is 180, but this patient did not have any prior cardiovascular event. What are you going to start this patient today if he attended to you in the clinic? So I'll take you back from the early days when we used to focus on glucose, and our first trial, again, I presented in my previous talk, the UKPDS, and the UKPDS has shown that intensive glucose control reduces microvascular complications. And the macrovascular complication and mortality benefit emerged only after 10 years of post-trial follow-up. And this is the most important trial that tells you early intensive glycemic control is important. So intensive control, lowering of A1C is quite beneficial, but it is very slow when we talk about macrovascular complications. And it's important only when you treat early. Why I did say this? Because if we look at the other trials like ACCORD trial, ADVANCE, and VADT, in the ACCORD, we looked at intensive targets in long duration in high-risk type 2 diabetes. There was no MACE benefit, and there was excess cardiovascular death and mortality. While in ADVANCE trial, we did see that there is an intensive glucose control in high-risk type 2 diabetes. There was no reduction in macrovascular complications. And the same for VADT, where intensive control in long duration diabetes, there was no significant MACE benefits. So in these three trials, we did not see any benefits in intensive control because it's a longer duration diabetes, while in the UKPDS, it was early, newly diagnosed patients with type 2 diabetes. So intensifying alone does not offer protection, cardiovascular protection, and it might be harmful as well. So that was the first thing we learned, that we need to intensify, and we need to intensify early. So what was our next step? Our next step was combining two drugs together early on. Is it going to be helpful or not? So that was tested in the VERIFY study where metformin and vildagliptin were combined early. And the primary endpoint in this study was time to initial treatment failure, where A1C goes above 7% on 2 consecutive visits at 13 weeks apart. So the result was the early combination improves the glycemic durability, where failure of metformin alone is being delayed for a longer duration when you combine it with vildagliptin. So if you combine medications early, you prevent the inertia, you're going to get an early sustained control, and that is more important than late intensification. So from these trials, we learned also that early control, longer duration might result in macrovascular mortality benefits. However, late intensification and tight targets very late might be associated with harm and increased mortality. So now, comparing micro and macrovascular complications with early control, we know from the UKPDS, you get it very early for protection for the retina, protection for the nerves and the kidney, and you get a very slow, longer duration benefits for cardiovascular benefits. So the cardiovascular benefit here is being filled by this gap is being filled by the new medications. But the question is, why did we start looking for new medications? And I guess the question is quite clear. It's the rosiglitazone story, where it was found to be associated with increased risk of angina and cardiovascular events, and consequently, the FDA has signed a rule that each and every medicine for diabetes has to go a cardiovascular outcome trial. And cardiovascular outcome trials, there are very important terms that we need to know when we talk about cardiovascular outcome trials. Number one, the non-inferiority and superiority trial. The non-inferiority means there is safety, and when we say the drug is safe, it doesn't mean that it is beneficial. The second is composite MACE endpoints. When we talk about composite MACE endpoints, we talk about three specific points, which is myocardial infarction, stroke, and cardiovascular death. So this is the MACE. This is just a reminder. I know you all know this. And then we talk about event-driven design. Most of the trials were event-driven. What does that mean? When we say it's an event-driven, it means that the trial will continue until we reach a certain number of events. And when we reach that number of events, it tells us that the trial is statistically reasonable to calculate benefits of that drug or not. And there are trials with most of the earlier trials were versus a placebo, while others were versus a comparator, like the SUMMIT trial, cardiovascular outcome trial for tirzepatide, where it has been compared to an active comparator, which is dulaglutide. Now, I'm going to take you through the benefits of all the classes, and we'll take it one by one. So we're going to look at the benefits organ by organ. And we'll start with the atherosclerotic events. Atherosclerotic events, I feel the winner in the atherosclerotic events is the GLP-1. And when we talk about atherosclerotic events, we talk specifically about the myocardial infarction, and we talk about the stroke. These are the most important atherosclerotic events, and with them comes the cardiovascular death. In the LEADER trial, liraglutide has shown significant benefits. The MACE events were 13% in the liraglutide group compared to 14.9%, and that resulted in around 13% reduction in events, and the number needed to treat was 53%. The benefits in liraglutide study were driven by myocardial infarction, and cardiovascular death, where in SUSTAIN 6, which is semaglutide, another long-acting GLP-1, they were around 26% reduction in events, and they were mostly driven by benefits in stroke. So each of these has resulted in MACE benefits, but each one through a specific atherosclerotic event. When we go to the SGLT2 inhibitors, the EMPA-REG was the first one, and the EMPA-REG, the events were driven, the benefits were driven by reduction in cardiovascular death, and the number needed to treat was around 46%. The cardiovascular or the MACE was reduced by almost 38%, 38% reduction in cardiovascular death in the EMPA-REG outcome trial. The canvas also, the MACE hazard ratios were quite significant. There was around 14% reduction in events, and the population in the canvas trial were mixed cardiovascular risk population, while in the EMPA-REG they were very high risk. When we came to the DECLARE TIMI, we didn't see benefits in cardiovascular death. However, the population in this trial were lower risk to start with. When we come to heart failure benefits. If the winner is the SGLT2 inhibitors, the DAPA heart failure has shown around 26% reduction in events, where number needed to treat was only 21 patients. And this is in patients with reduced heart failure. When we look at patients with reduced heart failure, the empagliflozin has also shown around 25% reduction in events, with a number needed to treat even a smaller 19 patients. So because of these benefits, actually the ADA 2026 recommended SGLT2 inhibitors in patients with type 2 diabetes and reduced ejection fraction, irrespective of A1C. And I'm going to repeat this word, irrespective of A1C, with each and every outcome that we talk about. When we came to the Emperor Preserve, the Emperor Preserve, there was around 21% reduction in events and heart failure, and cardiovascular death was reduced by 9%, but that was not quite significant. However, heart failure hospitalization was reduced by around 29%. And it's important to remember that the effect in preserved ejection fraction is carried by the heart failure events, not by the cardiovascular death. As I mentioned, cardiovascular death was not significant in preserve. However, the heart failure was significantly reduced in this trial. If we look at the SUMMIT study, which is a tirzepatide study, they looked at not diabetes related, they looked at obesity related heart failure with preserved ejection fraction. The results were stunning. There was around 38% reduction in events, and these were driven by worsening heart failure events. And this study specifically made the ADA put the following recommendation. The recommendation 9, which says in people with type 2 diabetes, obesity, and symptomatic heart failure with preserved ejection fraction, the use of tirzepatide, a dual GIP/GLP-1 agonist, with demonstrated benefit for heart failure symptoms. And the evidence is basically from SUMMIT trial. While the second one, they recommended extending other GLP-1 receptors with demonstrated benefit in this population. So we have now evidence for heart failure in patients with reduced and preserved ejection fraction, in patients with diabetes, in patients without diabetes as well. Now, if we look at the finerenone, the non-steroidal MRA, in the Fine Arts heart failure trial, it has reduced the events by around 16%. Again, making it a very good, reasonable resort in patients with heart failure with type 2 diabetes. The reduction, the hazard ratios were basically quite significant. There was worsening heart failure events was the driver of benefit in this study. If we look at the kidneys, so we're done with the atherosclerotic events, we're done with the heart failure events. If we look at the kidney events, this again, the SGLT2 inhibitors has shown quite significant benefits, starting from Credence trial, which showed quite significant reduction in renal specific composite outcomes of around 36%, and the hazard ratio was reduced by around 30%. The DAPA-CKD again showed quite significant reduction in events with a number needed to treat of 19. And in the kidney trials, usually the composite outcome is not again the MACE. It's basically outcomes related to the kidney, which is end-stage kidney disease, doubling of serum creatinine, renal or cardiovascular death. The EMPA-Kidney study was the last renal outcome trial to be conducted. It has brought down the eGFR to 20, and it has included patients without microalbuminuria. So making that, extending the benefit of SGLT2 inhibitors from only patients with proteinuria to patients with non-albuminuric CKD as well. And the second drug that has shown benefits in renal outcomes is the semaglutide in the FLOW study. It has shown quite significant reductions, whether in major kidney events or kidney-specific composite outcomes, or even death from renal or cardiovascular causes, making it one of the essential and important options in management of diabetic kidney disease. So if we look at the kidney, the GLP and MRA basically are standard treatment for patients with CKD. And the ADA recommendation here says simultaneous SGLT2 plus non-steroidal mineralocorticoid agonist may be considered if the albumin creatinine ratio is more than 100 and EGFR is more than 30. It also says that GLP-based therapy should be continued or initiated on dialysis to reduce cardiovascular risk. And this is one of the important recommendations, that it can be started during dialysis and it can be continued during dialysis as well. The KDIGO 2026 has updated the guidance to align the guidance with the 2026 guidelines, where GLP-1 can be used in this group of patients. If we come to the SURPASS cardiovascular outcome trial, this is a different trial because I've mentioned that this is a trial with an active comparator. And when we compared with an active comparator, it did not show superiority. It actually showed non-inferiority in this trial. And it showed that the 3-point MACE was reduced by around 8%, and that was not statistically significant. All-cause mortality has been reduced by around 16%, and that was quite lower in tirzepatide compared to dulaglutide. The death events were also lower in patients with tirzepatide, making it more stronger choice or a better choice than dulaglutide in patients with diabetes and cardiovascular, high-risk cardiovascular patients with diabetes. If we look at cardiovascular benefits in obese non-diabetic patients with pre-diabetes, semaglutide might seem to be a very good option, where you could see around 20% reduction in MACE events. And these benefits are not linked at all to A1C, as those patients are not really diabetic, they are having pre-diabetes. And the pooled semaglutide analysis showed around 16% kidney composite benefits in this group of patients. So what we would like to say now, that the glucose lowering effect of these medications, specifically when we talk about SGLT2, it fades below an EGFR of 45. However, they retain their organ-specific benefits, whether to the heart, to the kidney, whether to the heart or the kidney, despite no further lowering. And that says that these drugs act in non-A1C related or non-glycemic sort of action. So from this evidence, how can we look at our prescription right now? So if we have a patient with established atherosclerotic cardiovascular disease or a high risk, then GLP-1 should be a choice, plus or minus SGLT2 with proven benefit. If we have a patient with heart failure at any ejection fraction, whether preserved or not, SGLT2 inhibitors will be a very good choice. And if patient had an obesity and preserved ejection fraction, then tirzepatide will be a very good choice in this group of patients. In CKD, SGLT2 inhibitors, as long as EGFR is more than 20, and if it is less than that, GLP-1 is a reasonable choice. In patients with obesity and MASH, then GLP-1 based therapy should be the first choice in this group of patients. So what about combining classes? The FDA actually recommends permitting simultaneous initiation of SGLT2 and non-steroidal mineralocorticoids, as long as EGFR is more than 100, albumin creatinine ratio is more than 100, and EGFR is between 30 and 90. The KDIGO supports the simultaneous initiation if potassium is normal. And however, there is no head-to-head trial in all these medications. So what we should not lose now. We know that these drugs are important, but despite all what we have said, metformin still remains reasonable first line in low-risk patients. And that organ protective effect should be considered at the time of diagnosis. And we need to risk stratify our patients. As Dr. Hani mentioned earlier, risk stratification is really very essential to start treatment in those patients. And it's always important to keep SGLT2 inhibitors and GLP-1 as a first-line therapy, consider them. Insulin can be delayed, but it should not be delayed for a long time because we need to avoid the inertia. What we need to learn is, number one, that there is no enough head-to-head trials. Access to medications is not available actually in all patients because the cost of medications vary between one region to another region. And we need to remember that frail patients and elderly population are under they're not included in good numbers in these large trials. And we should always look at the durability of benefits. How long benefits persist after discontinuation, we're not quite sure. Now, the generalizability of these cardiovascular outcome trials doesn't fit because they are done in very high-risk patients, though in our population in UAE, I think we can generalize it because we looked at one of our trials here, we found that around more than 90% of patients attending clinics are high or very high risk. So that can work in United Arab Emirates, but I'm not quite sure in other countries where the cardiovascular risk is lower. So back to my patient who's a male, 52, newly diagnosed, A1C 8.2, BMI is high, eGFR is normal, and he has albumin creatinine more than 20, which is 180. If we look at these parameters in this patient, number one, the patient is obese and he had renal impairment, then SGLT2 and GLP-1 should be considered alongside lifestyle and RAS inhibitors as he's diabetic as well. So we choose it for kidney protection, we chose GLP-1 for obesity, and these two drugs, we choose them regardless of A1C. I'm sure once you start, A1C will drop, but even if A1C is low and the patient continued to have albumin creatinine ratio positive, then in that case, we continue with these medications and we don't discontinue the medications. So what are the takeaway messages? The first one is that the outcome benefit is a property of a drug class and not related to A1C whole. The phenotype decides the agent. If the patient is obese, GLP-1. If the patient has renal impairment, heart failure, SGLT2. If the patient is obese and heart failure, dual GIB, GLP-1. And there is a gap now in delivery, not in the evidence. We need to deliver our treatment for patients cost effective, as well as we need to manage our patients and protect their hearts and kidneys as well. And that was my last slide. Thank you very much for listening.
Thank you so much, Dr. Ala, for this comprehensive review, amazing talk. So now we will move to the third talk, which will be about type 2 pharmacotherapy in the latest guideline. And our speaker is Dr. Mohammed Hassanein, who is a consultant endocrinologist and professor of medicine at Mohammed bin Rashid University, and he is the chair of Diabetes and Ramadan group. Dr. Mohammed is well known for his great contribution, not only to the science, but also to the education. So welcome, Dr. Mohammed, and the floor is yours.
Thank you very much, Dr. Raya. Great pleasure to be with all of you. Let me try to share my slides. Okay, so it's been really great pleasure to be attending all of these eminent lectures. There's bound to be a bit of overlap between us, but what I will try to do now is to give you my perspective from a practical point. I'm not going to put studies and evidence because that has already been thoroughly covered by my previous speakers. I have no conflict of interest for this presentation. So, choosing the right drug for a person with type 2 diabetes. Let me assume that I'm a primary care physician or a specialist with a patient coming to me to clinic. And as you've just heard, we need to think of certain points. 4 main points: the cardiorenal risk of the individual, the glycemic target for that individual, the impact of the treatment I choose on the weight of the person, and of course, a number of other added factors, such as the risk of the hypoglycemia relevant to the individual, the cost, the side effects, again, relevant to the individual, and finally, which is the most important, the acceptability of the drug to the person. So you see, I've been repeating the word individual frequently because at the end of the day, you have a human being in front of you and you need to treat that person taking into account all of this. I'll be reflecting on our latest Emirates type 2 diabetes guidelines, on the cardiometabolic guidelines, as well as the latest ADA standards of care in my thoughts for today. So it's clear to all of us in any guidelines, and we've clearly written this up, as well as obviously been mentioned by all the guidelines. Number one, has been mentioned by Dr. Ala and all the others, and Hani, I'm sure, is we need to think not just of the glucose, but beyond the glucose. And many people thought that the word glucocentric means it's not important to manage the glucose. We'll discuss a bit later. But in red here, I highlight the number one issue to discuss the cardiorenal metabolic risk of the individual and then start to think of the options. We have seen the guideline change a lot. Up to 2015, we were talking about glycemic control. And then based on many of the studies that Ala have shown you recently in the last presentation, we started to think of drugs that will have an impact on the cardiovascular mortality, and beyond that, for example, for the heart failure, and certainly for the atherosclerotic problems. And indeed, the renal aspects have been following this as well. So the latest guidelines take all of this into account. So you have a patient who came to your clinic now. How would you assess the cardiorenal risk level? We have explained that thoroughly in the cardiometabolic guidelines, as well as in the type 2 diabetes guidelines. Take full history, take detailed history, ask thoroughly about the cardiovascular risk factors, do a full examination, including the ankle brachial index and the Doppler if you have it available. Do a retinal examination as well. And then order the essential investigations that need to be done a minimum of once a year, which would include, of course, the ECG and the proBNP, the renal parameters of ACR, serum creatinine, and eGFR, the lipid profile and the CBC and HbA1c, and possibly you can add B12 and TFT on the first consultation and thereafter according to the needs. So if you want to come to the decision of how is the risk of my individual, of course, you have to do all of this. Thorough history, smoking status, full examination, including certainly the feet examination and the ABI, and then these important 5 different profiles to do to get the risk of the individual. Now, if your patient in front of you score positive in these, for example, the investigation shows renal impairment or the examination shows retinopathy or heart failure or poor circulation, that person is a very high-risk person. That person before you start the pharmacotherapy, you advise them on the lifestyle measures, the smoking, the weight, the physical activity, the stress, and of course, early referral, and you stratify that person as very high risk. If your person scored negative, then you start looking into the other cardiovascular risks. And I'm delighted, as per the presentation of Professor Hani Sabur, that major international guidelines are also looking into the age of the individual and the duration of diabetes, as well as the number of classic cardiovascular risks. And according to that score, the person could be again classified into very high risk, moderate risk, or low risk. Is that important? Of course, it's very important, because that will dictate what you start. So in that person, without thinking, you need to consider and discuss a GLP-1 or a GLP-GIP or an SGL2 inhibitor with proven benefit, regardless of the level of HbA1c. In fact, you can do that in the stage of prediabetes as well. Now, there are preferences for the SGL2 versus preferences for the GLP-1, but if one is not suitable or not tolerated, you go for the other straight away. Now, if the HbA1c is still above target, you go for the other one. So if you opted for one, let's say a GLP-1 or a GLP-GIP, and the person is still not in target, then you add the SGL2. Now, because of this is a very high risk, whenever you think of a drug, you think of drugs with proven benefit for cardiovascular disease. Metformin have evidence, pioglitazone have evidence. So if there is no contraindication, if there is no intolerance to one of the drugs, you add them when the HbA1c is out of target. And then finally, if you need to add any of the other glycemic agents, do so based on efficacy, risk of hypo, impact on weight, on cost. So the first step is identifying the level of risk of the person. But you see that the second step is dependent on the target. And that's important. And of course, insulin come here as a last option. The high risk category, you could add or switch drugs with benefits. And of course, if above target, then you use the same methodology of using one of them. And finally, you add, after the metformin and the pioglitazone, you come to the other agent. So we talked about targets. What is the target for your individual? And of course, when you start to think of the target, you need to achieve that with low risk of hypoglycemia, specifically for certain individuals. And as you can see here, because this debate that is a false debate, glucocentric or not glucocentric, all of these columns are crucial. You cannot have a building with without one of these columns. So of course, you need to think of the drugs that have benefit for the heart and the kidney. But equally, you need to have very good glycemic control. And we've listened today to beautiful presentations about lipid management and of course, blood pressure management on top of what? Of a lifestyle modification foundation. So this is really quite important. The evidence for reduction of the benefit of glycemic control is not just for the benefit of saving lives, but also for the benefit of living life comfortably. I don't want to live my life with bad neuropathy or with bad retinopathy or certainly nephropathy. So it's not just about the heart and the kidney. You treat the person as a full entity, not as parts. And I want to stress on the importance of glycemic control, even for cardiac events. So this is a very beautiful data that looks into hospitalization for heart failure in people who have type 2 diabetes and predicting death from any cause, acute myocardial infarction, stroke, or hospitalization for heart failure. And see here in patients with coexisting conditions at baseline, then HbA1c is top. Acute myocardial infarction, HbA1c comes as top. So HbA1c is a very important, and here for stroke, HbA1c is top. For again, for patients with coexisting conditions, HbA1c is top and very important. So what we know that unfortunately a large proportion of our patients in UAE, in America, in Europe are not achieving their targets. So it's really quite important that after thinking of the SGLT2 or the GLP, GIP or GLP, that's not the end of the story. That's the first crucial step, the first important column, and the others are equally very important columns. So it takes me to what is my targets. And nowadays, because of the beauty and the power of some of the very powerful glycemic agents, we are able to aim for targets less than 6.5. In fact, we sometimes look that our patients have reached normal glycemia. Now, we are happy to do this when the person is young, fit, and healthy. For most adults, having the target below 7 is okay, but it's not necessarily the target, because for some, you might be able to aim for less than 6.5. Now, as health or age get a bit more difficult, then the targets start to relax a bit. So, for example, in people who have health issues or the older adults, it would be acceptable to have less than 7.5. As the age progress or the health becomes more difficult, then you can aim for 8. Of course, for someone who's hospitalized or with limited life expectancy, your aim is to avoid symptoms of hyperglycemia rather than an HbA1c target. So very much when you choose your target, you need to think of the risk of hypoglycemia and that the treatment doesn't add extra risk or burdens for them. And of course, it needs to help the cardiac and renal and the weight benefit with without really major comorbidities or contribution to this. So this is a very important point, that you need to think of this stepwise approach. But what about a person that I've assessed my patient, and specifically in our region, we have a large number of people who are diagnosed with diabetes at young age. This is different from when I was working in UK, where the majority of my patients were in their 60s and their 70s. Okay? So it's important to think of glycemic efficacy. So people who are low or moderate risk, after doing that exercise, this thorough exercise of screening, examination, history, and all the necessary tests, if that person comes to be moderate or low risk, then you can choose any agent that will achieve you the level of efficacy. So efficacy is key here. If my patient's HbA1c is pretty high, then I need one of the very high efficacy drugs, tirzepatide, semaglutide, insulin, or combination therapy. If it's just high, then the other GLP-1 receptor agonists, metformin, TZDs, or sulfonylurea. The moderate efficacy is for DP4 inhibitor and SGLT2 inhibitor. And that's really quite important. So when you look into your HbA1c of the individual in front of you, and you've decided the target in front of you, then you will be able to choose whether I'm not too far, moderate efficacy would be enough, or I need a high efficacy, or I need a very high efficacy. And of course, we need to think as well as on the impact of weight, and certainly to think of insulin. So when you think of insulin, you sometimes think of insulin early, because the HbA1c is pretty high and the person in a state of glucose toxicity. Usually, it will come after initiation of a GLP-1 or a GLP combined with a GIP. But in case your patient has no access to this type of therapy or not tolerating that type of therapy, then you need to think of insulin. Now, if the fasting blood glucose is the only problem, then basal insulin is the right choice. However, if it's the postprandial glucose plus or minus the fasting blood glucose, then you need to think of mixed insulins, co-formulation, or basal plus. Of course, when you start one of these steps, if the control is still poor, then you need to add the other component of insulin. So if you went for basal, then you need to add the prandial component as well. And here you would intensify to straightforward basal bolus after intensifying with all of the other oral therapy. So we discussed the cardiorenal risk, we discussed the glycemic target, and now we need to think of one of the main pillars as well, which is the weight. Now, it's very important that we think, as you think of glycemic management, you need to think nowadays of the impact of the drug on weight reduction or on weight. So if my person is within normal range of weight, then I don't need to think necessarily of obesity types of drugs that are high efficacy. I can choose any drug. But many people with diabetes have an obesity problem. And if that is pretty high, then the highest in efficacy is tirzepatide and the subcutaneous semaglutide, followed by the other GLP, dulaglutide, liraglutide, and semaglutide oral. And I presume we can add now to this orforglipron. The moderate efficacy is the other GLP-1 and SGLT1 in weight reduction. But of course, you can also opt for drugs that have minimal impact on weight, such as weight neutrality with DP4 inhibitors, and some of the other drugs that metformin, of course, is weight neutral, sometimes associated with minor weight loss, and not all sulfonylureas cause weight gain. Some of them are weight neutral in many of the studies. So you see here, again, this follows exactly what the ADA is saying. When you think of weight, think of the power of the drug, and then you will be able to decide the very high, high, or intermediate, or the neutral, as I mentioned, and here is the metformin and the DP4 inhibitors. But that's not the full story. I need also to think of other important factors: impact on hypoglycemia, cost, side effects. So let me give you an example. I'm a doctor, I work in an office, so having a mild hypo or moderate hypoglycemia is not a big problem. But if I was working, for example, as a carpenter or someone who works on heights, then any hypoglycemia would be very dangerous for me. If I'm a taxi driver, a bus driver, then hypoglycemia has a much more serious impact. And that's why knowing the social life of the person is really quite important. Think of side effects. If I have GIT side effects, then perhaps an incretin as GLP-1 or a GLP-GIP might not be the best. Or if the person have a history of repeated genitourinary infections, then SGLT2 inhibitors will not be the best. Of course, the cost of the drug is very important, and it's not mentioned in our recommendation because we didn't want to influence the decision makers that opt for the cheaper one. We want to opt for the best, and then sometimes life forces us for the compromise. After all, the acceptability of the person with diabetes is paramount. So you will find in our guidelines detailed information on the glucose lowering efficacy, the risk of hypo, impact on weight, MACE, heart failure, CKD, as well as MASH. And that is clearly mentioned for all the therapies that you have available. I would advise you to go for them thoroughly, one by one, so that we can come to the conclusion of which drug I can prescribe for my person with type 2 diabetes that I'm treating now. Of course, don't forget, insulin is a very powerful drug, but it comes with an impact on hypos and weight gain that we need to avoid. I like the idea that the ADA in their tables have also mentioned the cost, very clearly the cost per milligram as well as the average cost. And of course, because many drugs have different providers, the generic as well as the original ones, they put the different costs. Yes, definitely this is not the cost here in UAE, but we need to also reflect on the cost of the medication in relation to which person we are treating. Not every person is able to take any drug regardless of the expenses. So I don't want to exceed my time. My colleagues have thoroughly discussed many of the evidence for this. So I want to repeat important messages. Dysglycemia, including prediabetes, is a very important issue in UAE with cardiometabolic disease continuum. We need to manage the problem, not just the glucose aspect, but also the impact on the heart and the kidney and the metabolic aspects as well. Of course, we need to think of the other cardiovascular risks, and we need to think of the lifestyle of the individual so that we can minimize all of these aspects. As you have heard in me always talking about the individual, because for one person, a drug might be very suitable. For a similar person, different circumstances might not be suitable at all. So certainly think of individual approach, but following the systematic approach that I've outlined. And of course, early treatment and early referral, if necessary, are really very important. So again, my first slide, determine the cardiorenal risk of the person, determine the glycemic target for that individual. Not every person have the same target. The impact of the treatment on the weight, maybe the person is obese and need high efficacy of weight as well, or maybe they are in good weight and it could be well enough to have weight neutrality. Certainly, the impact on hypos, the side effects of the drug, cost, and the acceptability of the individual is paramount. And with this, I thank you with pictures of my beloved city, Alexandria, and happy to take questions at the end of the meeting. Thank you very much.
Thank you so much, Prof. Hassanein, for this elegant, comprehensive talk. So now I invite all the speakers to the Q&A session. So we have some, also Dr. Mark have joined us. Welcome, Dr. Mark. So to start with, so if everyone is there, I would just ask you regarding some questions that anyone can have an input on, but maybe we'll start with Dr. Hani. So Dr. Hani, regarding the risk assessment and all the physical examination steps and the tools that have to be used, to facilitate this, do you use nurse-led tool screening, or how do you do it in your clinic? So in busy clinic,
this
maybe
is,
the physician.
Yeah, so this is kind of standardized, and if any of the colleagues at Imperial Diabetes Center are also there, this is what we have put in as a standard algorithm. So annual assessment will include an ECG, so it's automated at the nurse level. So before the patient comes to the doctor, the nurse is acquiring an ECG annual package. The NT-proBNP, and in some cases troponin, selective, but everybody gets an NT-proBNP. Ankle brachial index annually, eye examination, foot examination annually, and of course the EGFR and the albumin creatinine ratio. This is added to the standard diabetes package. So HbA1c, lipid profile, triglycerides, all of that. So when this is done annually, and I think the main thing that I think Professor Hassanein highlighted, we're including younger patients from the age of 30. We're including diabetic and pre-diabetic patients, right? So it is really a very comprehensive screen that was ultimately approved and endorsed by the National Health Insurance Company, which is Daman, approved by the Way Health Authority, approved by Abu Dhabi Department of Health in the standards of care for diabetes. So in a way that this is casting a very wide net and catching patients that would be difficult to catch based on symptoms alone. Yani if you ask these patients, they typically don't volunteer symptoms. They tell you, I'm deconditioned, I'm tired, I'm obese, I have arthritis, I never exercise. So by capturing these patients prospectively, I think we have done a very nice job. As a matter of fact, this will be published very soon. We were part of this ADOPT study, which used the biomarker approach. In Imperial Diabetes Center was the main recruiting center, as well as some other places. And we found that 31% of patients who had simply type 2 diabetes and didn't have known coronary artery disease or known heart failure, 31% had an elevated NT-proBNP and therefore qualified for the addition of SGLT2 inhibitor, qualified for addition of ACE or ARNI, and qualified for further treatment, including diuretics. So if you screen, you'll find 1/3 of the patients, and this is huge. Yeah.
Excellent.
If I could add to this answer, because it's such a crucial question, Dr. Raya, because it tackles the structure of how you provide your service. In many centers, there is not enough people to help the doctor. And if the doctor in his consultation would do all of this, it would take them ages. So all what Hani mentioned could be done by the nurse. In fact, as well, the history of smoking, their job, all of these points could be answered by the nurse before the doctor comes in. Now, the doctor then need to take the other points as well as the clinical examination of the chest and the heart and the abdomen and so forth, and make the interpretation. I want the skills of the doctor to make the interpretation to answer the difficult questions rather than asking the tick questions. Do you smoke or not? How many do you smoke? How much do you walk every day? So forth. And certainly a trained nurse. So that is moving the nurse as well from glucocentric diabetes nurse to a comprehensive diabetes assessment nurse that we would like to have in our clinics. Certainly that would be the target as well, to help a comprehensive approach. That will save the health authority money, because if we identify the person and treat them early, then they would not need to end up with procedures, surgeries, or of course, death and serious comorbidities.
Excellent. So this is what I mean. So this takes me actually to the second question. So now many patients will come into the clinic. Even this is very important element to the primary health care and family medicine, where the patient will come will mention just to improve their glycemic control. So how we could help the primary care physician, how to approach this patient, rather shifting their focus from glycemic centric to the holistic centric, and to approach them in terms of CRM. So how you could advise the family medicine to do this, because this is a skill where you move the shift and the focus of the patient who came to your clinic asking only for better glycemic control to CRM focus, and then you choose the right options for them.
But Dr. Raya, if I may jump to briefly comment. My patient doesn't know anything about ACR or LDL, and they will give them no symptoms. Dr. Mark explained thoroughly, him and Hani, about the importance of LDL. That gives no symptoms. Albumin-creatinine ratio or mildly impaired renal function with an eGFR in stage 3A gives no symptoms. But nevertheless, we screen for them and consequently we treat thoroughly. So we need to guide our patients, but more importantly, we need to guide the managers to understand that concept and to provide that support.
Exactly.
What I could add, Dr. Araya, here is that we should stress on the point of screening, because screening actually detects all these comorbidities and allows you to treat patients earlier. So screening is really essential in these patients, plus risk stratification. If family physicians screen and risk stratified, then they will definitely give the right treatment.
And I think also the idea of taking this data into like a KPI or audit format. And right now there is a standard KPI about measuring NT-proBNP, right? If you don't measure it, you've missed an opportunity to detect heart failure in 1/3 of patients, right? If you don't do ABI, you're missing the opportunity to prevent diabetic foot. So I think these things are really concrete. And once the Department of Health made them into a standard of care, That means you have to meet the standard in order to properly manage diabetes. And ultimately, as they go to value-based care, they're going to start comparing doctors to each other, centers to each other. There's going to be maybe rewards. But I think it's very important to start with this basic idea. We must do these tests in order to find the risk in the highest risk patient. And the European Society of Cardiology considers a diabetic patient 10 years only or one additional risk factor as high risk automatic. So I think we really have to realize that we're dealing with a very sick population that appears to have no symptoms but is hidden under the surface, this iceberg effect. Yeah.
Absolutely, absolutely. And actually, this is the main idea from our session today. So just there are some few questions. I will try to cover them because they are very focused. One of them, if you could, Dr. Hani, or there is a question how to interpret calcium score as a risk stratification for patients who
Sure.
are asymptomatic.
So calcium score is a little controversial. If patients are less than 40, it does not pick up soft plaque. This is the problem. It is more, and all of the studies, the MESA score, where in the MESA study where the calcium score was utilized, were actually older patients. Secondly, if a patient is familial hyperlipidemia or have diabetes, you should not use the calcium score to withdraw treatment. For example, patient has a calcium score of 0 but has diabetes, you should never tell them don't take a statin because they are automatically as high risk. You use this in patients who are in a different category, an intermediate risk category, maybe a younger person who's 40 years old, who doesn't have severe dyslipidemia, does not have severe hypertension, who is reluctant to take a statin. You take the calcium score, it's abnormal, it's positive. In that case, stop smoking, take a statin. So it's used, I think, in the negative rather than the positive. At least this is my approach because we already have a high-risk population. Now, on the other hand, if you have a high calcium score from the beginning, you're in trouble. So if it's over 300, that's a patient who has established atherosclerotic cardiovascular disease. If it's between 100 and 300, that's still significant, and we are dealing with a younger population. So if you take the data from the international literature and you apply it to our population who is younger with coronary artery disease, I think we have to be careful about this. Yeah.
Yeah, no, I'll just add into that. Sorry, I couldn't be there for the live portion of attending in the CCU, but it sounds like a terrific conference. I think what you said is exactly right. People have, I think it's a great motivator for people who otherwise you might think are low risk. And then if you're not going to do a CT angiogram, do something with less radiation, they have a CAC score that's positive. That shows you they have some calcified plaque. But I agree with you 100% that especially in this high risk group, even though people talk about a negative CAC as having a good 10-year warranty, I think that doesn't hold true for young individuals. And I think for people with diabetes, I agree that they could have a fair bit of athero, and I would never de-escalate therapy based on a CAC of 0.
Absolutely. So welcome, Dr. Mark, and there is a question for you now. So what about the patient who are elderly with diabetes above age 80 with risk factors? How do you approach the dyslipidemia management in these patients?
Yeah, so in my talk, I indicated there is this odd part for the diabetes algorithm where it says if you're older than 75, maybe just a moderate intensity stent. I think that's crazy. So there is no evidence that the efficacy is any less in the elderly versus the youngerly. Now, obviously, as we do for every patient, you look at the patient in front of you. If they have, other issues that are changing their quality of life or their life expectancy, that might temper what you would do in terms of the burden of medicines you would have for them. But for patients with diabetes, as stated earlier, they are at very high risk depending on their comorbidities. But we showed in Vesalius, just having diabetes with one of those risk factors as simple as having it for 10 years or insulin use or evidence of microvascular disease, those people are at very high risk and they benefit. And they benefit by dropping their LDL cholesterols down to about 40 milligrams per deciliter, about a millimole. And that holds true regardless of their age. So I would not engage in any ageism and withhold therapy for an individual just because they're 76 versus 74 years of age.
Thank you very much.
Thank you so much.
wanted to follow up on this point. We all know that risk is age dependent. So by saying that the 70-year-old patient, you should think of a lower risk strategy, that absolutely does not make any sense. And I'm very glad that Dr. Mark is obviously one of the professors and investigators for the Vesalia study. Patients who did not have an event, who did have diabetes, this sort of high-risk primary prevention had a much greater upfront benefit of very intensive lipid-lowering therapy, which is exactly what the clinical studies have been telling us for a long time. So we do have fair number of patients who are, of course, we do have younger patients who comprise most of the ACS population, but we do have a lot of older patients who have multiple comorbidities, and I don't think there's any actually downstream risk of having more intensive lipid-lowering therapy. It's actually been shown that having a very low LDL in these patients reduces the risk of stroke and also reduces the risk of, multi-infarct dementia. So I think we should really question where that's coming from. It's not seriously evidence-based. Yeah.
No, I agree. And just to underscore what you said, because their baseline risk is higher and because they enjoy the same relative risk reduction, they by definition will enjoy larger absolute risk reductions with this therapy. So I agree. The recommendations to not treat them as intensively are completely topsy-turvy.
Yeah.
Thank you so much. So I have just a question, and it's open for everyone to comment on. So all these studies on cardiovascular outcome with the GLP-1 are based on the maximum dose used. Some of these elderly people will never reach the maximum dose that's used in the trials, and sometimes they will use it intermittently. So does intermittent use of the GLP-1 or a lower dose of GLP-1 in such case, any subgroup analysis or any other studies that showed still persistent benefit?
Well, I can, as a non-endocrinologist, as a cardiologist, but we're doing a large outcomes trial with the GLP-1 receptor agonist. It's a terrific question. I think, I would say that, and now this is in obese individuals with or without diabetes, but in the trials for obesity, there has not to date been shown any association between the baseline weight or BMI and the clinical benefit. And because the percent weight reduction or BMI reduction is constant regardless of baseline, that means that regardless of the absolute decrease in weight achieved with GLP-1 RAs, the benefit appears to be the same. In fact, people at the lower end of the BMI spectrum, if anything, numerically have slightly greater benefit, but certainly no heterogeneity. So it suggests that the benefit is not necessarily due to the weight loss, but perhaps due to GLP-1 receptor agonism and the benefits that flow from that. That being said, there have been in some smaller studies when they've tested two different doses. The higher dose did appear to achieve somewhat better outcomes. These weren't large trials powered to detect the differences between them. So my take on that is that the benefit will accrue probably regardless of, for people with obesity, regardless of what your BMI is. But that being said, the more you take the drug, the higher the dose of a given drug or the more potent a drug is, it may be that there's more benefit from that, but others may have different views. But I think it hasn't been rigorously looked at. But for the few trials which have tested two different doses in the same trial, the higher dose tended to have lower rates of outcomes.
If I could also add, there's two different studies. I totally agree with this point. The Harmony Outcome study using albiglutide, there was basically no weight loss at all. There was less than 0.7 kilogram weight loss, but there was a 24% relative risk reduction of hard outcome, MACE. And that was albiglutide, an older generation of GLP-1. In the SELECT study, as Professor Mark mentioned, patients who actually gained weight but were still on the semaglutide, and patients who had less than 5% weight loss on semaglutide still had a 24% relative risk reduction of MACE. So it seems that the weight reduction is not the main marker or I believe not the main function. It's the molecule itself that's having some anti-atherosclerotic effect. But you do get more weight gain with higher doses, which then has maybe impact on the traditional risk factors like hypertension and dyslipidemia and so on. So I'm really not terribly impressed with the narrative about the weight loss. It is really about specific molecules in the GLP-1 class that have cardiovascular benefit and others that do not. We also have seen the CVOT with tirzepatide, which was compared to dulaglutide, and that was non-inferior. So adding the GIP to the GLP-1 did not seem to give you more cardiovascular benefit than a comparator that has only GLP-1. So it's quite a molecule-specific effect. It's definitely not a class effect. And I think the weight loss is a cherry on top. The diabetes control is very important. I think that's really key, especially in patients with insulin resistance. But as you very nicely said, the patients with the lower BMI actually had a really robust reduction of cardiovascular outcomes. So I don't know how to actually make the insurance companies believe this. So here, the insurance companies only accept a GLP-1 if you have type 2 diabetes and on other medications have an A1C above 7. They don't buy the cardiovascular endpoint. They don't accept the weight loss category. So I think they have to change their practice because we are clearly talking about patients with hard cardiovascular events that are being reduced by this category of therapies. So.
And if I
Dr.
need to add to this important, sorry.
No, I was just going to ask him, I'll take just 10 seconds. Is it easier where you are to get a DPP-4 inhibitor or a GLP-1 RA?
DPP-4 is free.
Right? I mean, it's crazy, right? And the GLP-1 RAs have a big cardiovascular benefit for our patients. And the DPP-4 inhibitor is nice for glycemic control, but zero cardiovascular benefit, right? It's totally crazy.
And this was the point I wanted to comment upon. We spend a lot of time talking to each other when we are totally convinced about the evidence. We spend very little time talking to managers and decision makers, including insurance companies. And I believe that the major role of the society is to lobby on the behalf of the person with diabetes on the importance of the implementation of these guidelines, and not just necessarily to talk to healthcare professionals about this evidence. Many of them are convinced, but their hands are tied and they cannot prescribe.
Absolutely. Actually, this was one of my comment that if you look to the UAE population, which is a heterogeneous population, a majority of people who are living with high cardiovascular disease, they cannot afford these expensive cardioprotective medication. And therefore, I think one of the focus I thought, and I need really to hear from you, is that even in the future guidelines, maybe there have to be, as you have highlighted, Dr. Hassanein, that ADA has mentioned the cost. So maybe even apart from cardiovascular classification of the medication and how to be used, also to account the cost and insurance coverage, so that we stratify them based on the patient insurance as well.
Yes, I hinted to this in my presentation. Yes. When we were writing the guidelines, we opted on a consensus, not a unanimous approval, but on a consensus, not to mention the cost so that the insurance companies don't say, okay, let's use the pioglitazone instead. But having said that, it means that we need to lobby strongly to implement the guidelines. Otherwise, then we will end up utilizing less robust guidelines scientifically, taking into account the evidence, the cost, and maybe we say just use an SGLT2 inhibitor and maybe it's a generic one as they are now available as generics. But that will mean we would lose on the effect of a powerful molecule that have bags of evidence.
So without taking further time, we have just a few questions, maybe just short answer for them. One of them was wondering, is there any in the horizon, any injectable lipid-lowering agents that can be used during a pregnancy? During pregnancy.
So there are some case reports of patients who became pregnant after being injected with inclisiran. And nobody's recommending that, but inclisiran has this GalNAc ligand that is absorbed directly into the hepatocyte. So within 48 hours, there's no circulating level of the drug, and it inhibits the PCSK9 production in the hepatocyte. So that's totally off-label. I don't know that there is going to be a study in pregnant women, but there are accidental patients who become pregnant. There is sometimes we've seen some off-label use of PCSK9 monoclonal antibodies in the last trimester of pregnancy, but the standard, I think, is to use plasmapheresis or sort of therapeutic apheresis in patients with severe FH and coronary artery disease during pregnancy. But that's a very small group of patients. I don't know if Dr. Mark has any experience with that. I think.
No, I mean, you said it perfectly. I think obviously there's concerns for statins. I don't think any good data one way or the other for ezetimibe, and for PCSK9 inhibitors, there's really no data for it. In the trials we do, occasionally people get pregnant and didn't realize it. We find out during the trial. And so just as was said, there isn't any data that there's harm. But the lack of data then will get people concerned and stay their hands. And so there's not a lot of really, great options. There's bile acid sequestrants. No one likes taking those. And then obviously you could do apheresis for patients who have FH.
Excellent. So I think we reach to the end of this talk. Thank you so much for the talks, elegant talks, and for contribution. Just before we finished, if you have one message to deliver to the audience, just briefly, one message, each one of you.
I'm happy to start.
Everybody.
I would say that the message is, I think, for patients with diabetes, even if they don't have clinically known athero, they probably do have athero. They need to be treated aggressively, get their LDL cholesterol down to super low levels, to sort of under 40 milligrams per deciliter. You'll be helping them out by doing that, decreasing morbidity and mortality.
Dr. Muhammad.
I think we have beautiful guidelines. Certainly our local guidelines are really taking into heart the local needs. So my advice to my colleagues, healthcare professionals, use a systematic, structured approach.
Excellent. Dr. Hani.
Test everybody and react accordingly. Use SGLT2 inhibitors, use ACE/ARB/ARNI, use high-intensity lipid-lowering therapy, use GLP-1.
Excellent. Dr. Ala. Unmute yourself, Dr. Ala.
Sorry, I'd say individualize the treatment, look at your patient need, and target treatment accordingly.
Excellent. Thank you so much for all of you. Thanks for all of your contribution. And thank you for all the audience. And those who miss any of these modules, they can just go and view the recorded ones in the YouTube channel or EDS Institute. You have 1 month left, and you just need to answer the MCQs before and after the module, and then you can get your CME certification. So please don't forget to complete the post-webinar MCQs. Again, thank you for our speakers. Thank you for your contribution heavily into this series. And we wish to see you again, inshallah, in a future educational collaboration. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.